Good morning, everyone. Welcome to day two. We had an excellent day one session yesterday. Apologies for starting 10 minutes or so late. For those who know me, know that this is really causing me anxiety because I like to keep things on track. But we will make up for lost time as the day goes on. So today we have two application domains of digital public goods. The morning sessions are going to start with the healthcare domain, followed by the application of agriculture. And so it is my distinct pleasure this morning to introduce Honorable Minister of Health from the Republic of Sierra Leone, Dr. Austin Demby, who will be giving our keynote talk today focused on digital health. So if you can kindly welcome Dr. Austin Demby to the stage.
Thank you. Thank you very much, Conrad. Well, good morning. I don't see the slide showing up there, but again, we had a really wonderful evening last night, and it was really great to see the cultural display and the warm hospitality of our Rwandan colleagues. So colleagues, what I wanted to talk to you about today is we've heard a lot about digital health and some of the innovations that we saw yesterday. From a practical standpoint, I was trying to see how is this relevant to health? And for me in particular, how is this relevant to the Ministry of Health and the people of Sierra Leone? You could use it as a surrogate marker for what we're dealing with in Africa and perhaps the rest of the world as well. So what I want to do today is to ask all of you. I pose questions. I hope that I could define some of the challenges that I confront in my sector. And as you walk with me, I want you to see where are the areas in this effort that are amenable to digital solutions that you could help me solve problems with. Why don't we start with just some of the major global obligations that we have? Starting with the SDGs, in 2015, we said we'll share a blueprint for peace and prosperity for people and the planet now and in the future. We also made some major commitments, the 17 SDGs. Let's focus on SDG 3, which is a duty, an obligation to ensure healthy lives and promote well-being for all at all ages. We also have universal health coverage, which focuses on all people having access to healthcare services they need, when and where they need them, without financial hardship. And all of this is built on the foundation of primary health care. And what that assumes is that you have a whole of society approach with the highest level of care being delivered. You also have equitable distribution of this care so that no person is left behind. You want to also provide these services as close to the people as possible. So these are lofty obligations. Let's just see what the numbers say. Right now, we have about 7.6, close to 8 billion people in the world. We're projecting to have about 8.6 billion, 8.4, 8.6 billion by 2030. Africa alone now has about 1.4 billion people. We hope that by 2030, we'll have 1.4, 1.6 billion people. My Sierra Leone, we have 7.5 million people. My responsibility is how do I fulfill all of those earlier obligations that we set? Universal health coverage, SDG 3 fulfillment, primary health care for all 7.5 million people. The magnitude is huge. So this is beautiful Sierra Leone. Just in case you don't know, it's right on the Atlantic coast there. 7.5 million happy people with wonderful beaches. But we have some real health problems that today I want you to help me navigate what kinds of solutions we could bring to bear. We strongly believe in universal health coverage, which means every Sierra Leonean should have access to high-quality healthcare. However, our approach to this is slightly different because we're reimagining it. We're translating universal healthcare into what it means to us, and we understand it, and it means something to us, and we're able to apply our principles towards it. So our approach to it is not going to be disease-focused. It's going to be focused on life stages. And you work with me, and as we go through these life stages, you see where your applications are going to be very helpful. This is a very busy slide. But for me, this slide is the whole of the Ministry of Health. We've been used to having HIV programs, malaria programs, TB programs, reproductive health programs. All of these are focusing a lot of times on the processes and looking at what funds you have, and it's mostly driven by the funding agencies, looking at how you utilize those funds. And at the end of the day, it's ticking all of the boxes associated with your primary disease. But what's the point in having the best HIV program for pregnant women and the woman dies of malnutrition or the woman dies of typhoid? We've all lost. So what we're seeing in Sierra Leone is instead of focusing on the diseases per se, let's see where you have a confluence of all of these diseases, all of these interventions, focusing on the patient, on the client, patient or client-centered care. So if you start, for example, with a pregnant woman, there, I don't know if this is showing, just at the bottom left, you have the pregnant woman. If you go up in that column, what we're saying is, what are the programs that are directed at all pregnant women? What are the services that you're going to offer these pregnant women? And it shouldn't just be a dialogue. Why don't we set some clear targets for what we want to accomplish for these pregnant women over a set period of time and focus on the health outcomes associated with it? So it doesn't matter if you're working on malaria, you're working on TB, you're working on HIV, you're working on reproductive health. All of those efforts should be channeled at how does that benefit the pregnant woman, with the health outcome there being the primary objective that you're working towards. Again, if we fail to deliver the baby, a healthy baby, we've all collectively failed. So when this baby is born, that's the next challenge. We'll look at the next column. What programs do we have for these babies? What services do we have? What clear targets are we setting for us to accomplish for these babies? All the way till when they're ready to go to kindergarten. At kindergarten, early childhood development, what programs do we have? What services are we offering? What targets are we setting for ourselves? And how do we make sure that these children are not just surviving, but they are thriving? Till they go to school. What's your school health program? What are your services? And what targets are you setting for yourself? And what outcomes are you looking towards? Till they are young students, primary school, till they go to university, till they are adults, till they're senior citizens. My message to my team is, if you look at all of this and you don't find yourself in there, we have a problem. Because you should be working towards these life stages approach. A lot of people call it the continuum of care. I agree with the continuum. But what we've done in Sierra Leone is deliberately set up some gates, some stages where you check in. So we have these 7 check-in points. Now, for this to be very successful, it is important that you have some cross-cutting foundational issues, starting, for example, with a trained and responsive health workforce. You may be asking, how is that related to digital solutions? We want to be able to forecast the need of the healthcare workforce that we need. We need to be looking at training towards these forecasts. We need to be looking at the distribution of healthcare workers after they're trained. We're looking at their retention. This could not be resolved by a paper-based system when I'm looking at 7.5 million people. The e-solutions around those are very, very critical, and we need to think about it. Similarly, you could look at all of these pillars, the functional ambulance service, the referral system, looking at supply chain, looking at equipment infrastructure, and I know you all will be very, very interested at column 5, which is research, data, and information systems. Similarly, you're looking at health security as a major cross-cutting issue. I mean, Uganda will remind us that this is really quite important right now. And drugs and regulatory systems. These are clear platform activities that we need to address in order for us to be foundation structures for the life stages that we talked about in the last slide. So let me look at an illustrative example of what I'm talking about. How Sierra Leone has one of the highest maternal mortality rates in the world that we're not proud of. We want to change that narrative. So right now, you have 717 maternal deaths per 100,000 live births. I mean, it takes countries 10, 15 years to drop it by 5. But Rwanda and Ethiopia have really demonstrated that if you're determined, you could drop this precipitously. So for us in Sierra Leone, what we've said is we're going to reduce maternal mortality from 717 per 100,000 to less than 300 per 100,000 in 3 years. The reaction I get from people is either, wow, this is really exciting, no, let's do this. Or people are, you crazy? What's wrong with you? This is impossible. I like the former response because we're determined to make this happen. And it's not just a dream. We've translated that dream into 5 critical steps that I want to share with you today. And I would like for you to look at where the digital solutions fit into this dream. Number 1 is if you look at the very top there, it turns out that 14% of maternal deaths occur in teenagers, girls under the age of 20. In a lot of cases, they attempt to terminate the pregnancies that they don't want, and in the process, it goes wrong, and by the time they come to the hospital, it's too late. So I will focus on this 14% and see how we could make a major dent in there by looking at sexuality education in and out of school, by looking at commodities availability, accessibility, and affordability, by looking at providing C-section capabilities for young girls who are struggling to deliver, by also ensuring that, in Sierra Leone, we have what we call radical inclusion. That means you're not penalized for being pregnant, will allow you to deliver the baby safely and go back to school, and so it doesn't hinder your education. So with all of these components, we also offer that if you really want to terminate the pregnancy, don't find an illegal means of doing it. We'll create a safe way for you to deliver, to terminate the pregnancy. So that's our approach to reducing maternal mortality in teenagers. The next is we have 1,000 primary healthcare units in the country. That means 85% of the population have access to a health facility within a 5-kilometer radius. So that gives you access. Now the big challenge is how do we translate this access into quality care delivery? We look at that in multiple domains. First, infrastructure. You have to have this place appealing to somebody to want to come there and deliver. So physical infrastructure is important. Water and electricity are really critically important. A lick of paint wouldn't hurt either. And we want to be sure that if we have the physical infrastructure that's clean, that's available, you want to be sure that you also have the staff complement, the nurses, the midwives, the requisite staff that will be able to ensure the delivery of these babies safely. We also have blood services and pregnancy support. But one of the coolest things that we've done in Sierra Leone is to develop a new app. The new app that will allow women to register their pregnancy with geolocation. So when you register your pregnancy, we know that you're there. You could use this device to identify the clinic that you want to deliver in. You'll pick up that clinic and we'll ensure that there's a health worker there that's linked directly to you. And we'll work with the community to support that pregnancy. Normally you have about 4 visits with the health sector. We're expanding this to 8. And at every encounter, we'll do blood pressure, we'll do blood sugar, we'll look at comorbidities, we'll look at all of the kinds of things that will be obstacles to a safe delivery and try to influence that. We're not waiting for the end result. We're trying to influence the end result by having a safe delivery of the baby. So that's what we're doing as number 2. Number 3 is we want to have a very, very fast and effective ambulance service. So if you've identified high-risk patients, somebody who has sickle cell anemia, somebody who has diabetes, somebody who has high blood pressure, you don't only work to manage that, but also be available to refer them fairly quickly so that they could have better services. So the ambulance service is very critical. And the ambulance service has to have like an alert system, has to have a notification system, has to have response time issues. All of these are amenable to some digital solution or digital assistance in this case. That's the third. The fourth is we want to be able to move people into high-level secondary and tertiary care institutions. So the same principles apply to the earlier institutions that we talked about, except that at a higher level now, because you're only seeing more difficult cases. So you want physical infrastructure that's amenable to that. You want to have the requisite OBGYN experts and specialty nurses to take care of difficult cases. You want to be able to have the equipment and supplies for complex cases. You also want to have the drugs available to you. Most importantly, the fifth one, which is there in the brown or orangey color there, is the data. So now that we have all of this information with geolocation, I could sit here and look at a heat map and see where all of the pregnancies are today in Sierra Leone. I would like to be able to see where all of the near misses occurred last night. I'd like to see where all of the safe deliveries occurred last night. I'd like to know where all of the maternal deaths occurred last night. That way, I could sweep the data on a weekly basis. I know what's happening nationally. I know what's happening at the district level. I know what's happening at the chiefdom level. I know what's happening at the PHU level. With that information, I don't have to wait for a quarterly report or an annual report to respond. At the end of the week, if we have a flashing yellow light, if we have a red light somewhere, we'll deploy resources, we'll deploy a SWAT team to go work with the local partners there to see what are the problems and help resolve them. What we want to do in Sierra Leone, when I said 717 per 100,000 live births, I really hate to say that in Sierra Leone because it's statistics that academics will understand. But the average person doesn't know what that is. Now, what that means is if you have 44 50-seater buses, 44 50-seater buses full of pregnant women dying every year, that's the crisis we're dealing with. And so it's not, for Ebola, we had 4,000 deaths in over 2 years, which is about 2,000 deaths a year. We had an emergency response to it. Now we have 2,100 deaths a year on a consistent basis. It deserves to be considered an emergency. So in Sierra Leone, what we're trying to do now is to declare this an emergency and use the emergency principles of response by incident command, by structures that look at a daily activity, by looking at daily response. Every time a woman dies, it's an incident that we should not allow to repeat itself. So that's the approach we're taking in Sierra Leone. So coming to where we are now, some of the challenges that we have is, with UHC, it's been difficult to achieve the SDGs because the information systems remains a real challenge. It's very fragmented. It's very, very disease-focused. Everybody is supporting their own e-solutions. And I think it's going to be very difficult to be able to move all of these together if we're still following these fragmented solutions. I mean, granted, you have funding for particular things and you have expectations around it, but we should be focusing on interoperability and seeing how we bring these things together to answer the kinds of questions that we want answered. As I said before, I'm not a tech geek. I don't understand these things. What I do is ask the right questions and share with you my problems so that you help me solve it. You have to have public trust and data security, especially when it involves personal identifiable information. Most investments, as I said, are vertical. We need to be able to make sure that we have interoperability and system-wide approach. And we shouldn't be focusing on different solutions that are not designed for robust coordination. So some of the solutions, clearly the digital public goods solution is something that we all adhere to. I mean, WHO has a similar approach, but it looks like these two could be aligned very well. And I think at the end of the day, what we want is to ensure that you have a trusted system that could create secure and accurate information that will help us do our work better. So I know that you're going to have breakout sessions where the experts are going to sit down and talk about these things. And I really want to, as you're working on the mechanics and the engineering and the data and the coding that's going on there, remember that we're working for these beautiful people. Those should be the focus of our attention. Whatever solutions we bring, they have to be user-friendly. They shouldn't be for you. You're not doing it for yourself because you know how to do it. These solutions should be for the average person in the remote area that's able to use it to help us achieve our objectives. I know we can do it. I believe we can do it. And I want to thank you for the opportunity. Thank you.
Thank you very much. I think we have some time for some Q&A. Okay. So before we have Q&A, I do want to do an informal poll. How many people have been to Sierra Leone by raise your hands? Been to Sierra Leone? Okay. If you asked this question maybe a year ago, there would have been less people. We did have a conference in Sierra Leone in May, and so thank you for some of the participants being there. So I do want to open it up for Q&A from the audience just to get some additional thoughts and feedback from our Honorable Minister. Any questions from the audience? Okay. And if we can get a second microphone, please.
Hi, good morning, everyone. My name is Tom Olwoch. I'm with CDC right here in Kigali. Thank you so much, Dr. Dembi. First, it's really nice to see you again after many years. So thanks so much for your great vision for the people of Sierra Leone and for laying it out in a very clear strategy, targeting especially the young women or adolescents and young women who are getting pregnant and the interventions you're proposing. So my question, especially on the use of the app where pregnancies can be registered and followed through, linking them to health facilities and to health workers. I was just wondering, just thinking about the coverage of smartphones among that population that we are targeting. Because if there's low coverage or low access to cell phones, then registering those pregnancies may not be as successful as we would want them to be. So how about considering a situation where we target community health workers, have them have smart devices like tablets or some other mobile devices to be able to reach out to young and pregnant women so that, because we know it's easier to facilitate community health workers with devices to reach out and register pregnancies, as opposed to the other way around where we expect the young women who may not fully have access to technology to register those pregnancies. So just a quick thought for consideration.
Thank you very much. I mean, as some of you might know, I spent the better part of my life working for CDC till about 18 months ago. But that's a very good question. And I think for us, what we're looking at, you have very good cell phone penetration, but it doesn't go all the way. So what we're hoping for is those that are can afford it, are amenable, have access to smartphones, we'll make sure that they utilize the app very well. For those that are not able to, what we want to do is empower the community healthcare workers to be navigators to help them with it. And I come back to the fundamental principle here. It's performance-based. We know that, we all die at some point. But what we want to do is we give people the opportunity to do their best to avoid preventable deaths. So what you have is a partnership now between the navigator, the healthcare worker, the community, and the pregnant woman. And so with this team, they're all working towards the healthy outcome. And so what happens now, you have a little thing going on that where you have to trust the local people to innovate and see what works best for them, knowing that the ultimate objective is the safe delivery of the baby. So if I'm a health worker, I have 20 pregnant women I'm managing in my community. I get the community health workers there. Almost every morning I go around and do my rounds and see how are they doing, how's it going. It's your appointment to come to the hospital. If you don't come to the hospital could come to you. So again, I think the tech is just a tool, but the systems around the tech is really what's going to make it work. Thank you. There's somebody in the back.
Thanks very much for the talk. So my question is, you've pointed out that you're trying to shift from disease-focused interventions to more integrated approaches. And when it comes to digitization of healthcare services, the technologies tend to follow the disease-focused approach. And we have program-specific interventions like in malaria, and other areas. So I just want to understand, what strategies are you putting in place to ensure that even when we come to digitized solutions, we are taking an end-to-end approach and not taking a siloed approach? Thank you.
Well, thank you very much. Molibwanji, I shocked him. I worked in Malawi for 5 years, and I'm aware of the Baobab tool that was used in Malawi quite effectively. We know that funding has specific prescriptions associated with it. So everybody wants to respond to the funding. So what we're doing here is a dual approach. First, we're going back to, we just held a health summit in Sierra Leone and brought everybody together. The developers, the development partners, the ministry, civil society, and we all agreed that this is a way to go forward. What we were told by a lot of people was that, well, if you don't have a plan, we have a plan for you. So we'll fund our intervention, and we'll make sure that this intervention goes forward. So what we're trying to do now is, this is a halfway house. So you can still continue to fund your interventions, but if you're funding malaria, the output of your malaria work should not be just focused on the processes. You have responsibility to the outcomes of it. So in the end, we could go back and say, you had a very successful pregnancy, and we go down a checklist of what all contributed to that successful pregnancy. We could have a failure in that pregnancy. You could go back and check what didn't happen that led to that failure. So you could look at attributions after the fact. But right now, my primary focus is on the health outcome and collective responsibility. So now I don't work for malaria. I don't work for HIV. I don't work for TB. I don't work for all of these parallel programs directly. I work for the people. So what I'm trying to say is, how could you align your programs to make sure that they fulfill the needs of the people? It's not easy. That's where some of these digital solutions comes in, because you're not looking at a linear engagement. You're looking at a convoluted, multifaceted engagement. And at this early point, I'm not worried about attributions. I'm worried about the health outcomes. Yeah.
Thank you, Minister, for that amazing talk. So I have a question related to some of the conversations we had yesterday about distrust and misinformation. So that has been a problem, for example, in the US with like vaccinations, and there have been sort of segments of the population that have been disenfranchised or have traditionally mistrusted sort of government health initiatives. So I'm just curious about your experience from the deployment. Have you seen this kind of problems, or what like a policy or a government can do to avoid these kind of issues?
Well, I think that's a very good question. Sierra Leone has come through a lot over the years. You know, we were able to deal with Ebola for quite some time, and we realized fairly early that the whole notion of public health has to have a capital P for public. You have to engage the public early. The public has to be knowledgeable about what you're trying to do. And it should not be in technical language that only you understand. It has to be in a simple language that people understand. And people are always looking for, what is my role in generating the solution here? So if you have that mutual respect and say, look, nobody wants to see their daughter, their mother, their aunts die from pregnancy. Pregnancy should be a happy moment for everybody involved. And what we're trying to do is to see how we could help a pregnant woman deliver safely. If you do that homework and you come up with these ideas, and again, it's not a prescription, it's a tool. And you say, we're using this tool to be able to measure how well we're going. And by the way, in fact, you could create some subtle competition going in and go, look at the Northern Province, look at what they did and how they were able to change the health outcomes. Look at the other colleagues. By using these tools, it was able to help them accomplish this. So when you spend some time respecting the people you're serving and understanding that notion is you cannot create a solution for us without us, it is very important. So I would ask all developers, and I think that's what we've done quite a bit of in Sierra Leone. And again, you don't build trust on the day of the incident. You build trust in the quiet moments when other things are going on. They've seen you consistently give good advice. They've seen you consistently support them. They've seen you consistently listen to them. You have a joint objective of a solution. I think you begin to address, it's not perfect, it's a slower process, but when you get it right, you know, you see the results. In Sierra Leone, when we had Ebola, the first people who came in just said, Ebola is the deadliest disease in the world. Yes. There's no treatment for it. Yes. There's no vaccine for it. Yes. But when you're sick, go to the hospital. And people say, why? So having a conversation with them, for example, you say, well, when somebody dies, your mother dies, or your sister dies, or your aunt dies, or your niece dies, you can't touch the body. They go, why? If you take the moment and explain to them what you're trying to do and create a partnership with them, and in this case, people said, well, look, I don't like that body bag that you bring here. It's plastic. I'm not going to put my loved one in a plastic bag and throw it away. It's like trash. So don't bring your plastic bag here. But say, well, okay, well, look, why do we use this plastic bag? We want to contain the bug, yeah? We want to decontaminate and contain the bug, because if that's not the case, you're going to infect other members of the family and they will all die. He said, okay, well, what's the compromise? If you get me a coffin that will hide this body bag in a coffin, I'll agree to it. So we had a lot of these engagements where people's solutions were being felt. When we got all of those together, the transmission rate dropped precipitously. The safe medical burials improved considerably, and we were able to contain the outbreak. So I think there are lessons there that are applicable across the board as you develop these wonderful tools. Engage the local people. Your initial intent is in the right place. You want to do good. But if the people don't understand that that's what you're going to do, if the people don't understand that their voices are being heard, their opinions are being heard, you know, you're going to run into trouble. So let's work on these great apps, but let's invest in ensuring that people understand what these apps are and their voices be heard in the development as well.
Okay, thank you so much. I actually enjoyed the talk. So there is a question I have. You mentioned that the app that is being built or wish to build can reach an average person. You know, there are some people that are in the rural areas that are below average. They will not even be able to afford to have a cell phone that has some functionalities to be able to use that app to do anything. Now, how do we reach these people? Because that's a very serious problem, especially from where I'm coming from. So you're from Sierra Leone, that's West Africa, and it looks like a lot of things are working in your own area. I'm from Nigeria. We have the northern part where we have Boko Haram. We have all those areas that people don't even have access to such phone, and they're below average.
Yeah.
So they won't be able to do what we say use cell phone to do. Yeah. How do we go into these kind of areas? What is working in Sierra Leone that can be translated into these kind of areas?
Yeah. I think that question is similar to the earlier question that was asked, because I think what we're looking at is you don't have a solution, one solution fits all. You know? And I think what we're saying is for those that have access to phones, which is a fairly high penetration in Sierra Leone now. I could call my grandma and move money today in the village. But Sierra Leone, as you can see, is a round country. It's about 4 to 5 hours end to end. You know, you could travel fairly quickly. And so the phone network is penetrating, but it's not there yet. So what we're saying is for where the phone doesn't reach that last mile, what you want to engage is navigators, you know, local community healthcare workers that will work with you and work with the pregnancy as a team. So if you're saying even the community healthcare workers may not have access to this, what we're saying is, what does it cost to have a phone? When there was Ebola in the US, every time you arrived in the airport, they gave you a phone, yeah? So that they could track you. I mean, these phones, the other day I bought like a $5 phone in Sierra Leone. I put a $2 SIM card in it. It lasted for only 4 or 5 months. How about giving the pregnant woman a gift when they come in with a $5 phone and a $5 SIM support for it? That's for the pregnant woman. And have the community healthcare workers. You could give them tablets. You could give them phones as well. I mean, all of the, we don't have a perfect answer in Sierra Leone, but this is something we could collectively do. I really like to focus on, okay, we have a problem. What's the solution? What are we going to do? Life in this environment is like a hurdles race. You jump over one hurdle, there's another one. You don't stop. You jump over that one. You figure out a way to get to the last mile, to get to those people. But you cannot say, if we don't get to the last mile, we're not going to start. We're going to start and do what we can, and where it's much more difficult, we find innovative ways to get to that last mile. Again, I don't know how they'll have all of the answers, but this room, together, will find the answers.
Great. Thank you very much. If we could please give the Honorable Minister a hand. Thank you very much.